morning to everybody. It's a great pleasure and honor to be here. We have very good collaboration with the Swedish Heart Association, but also I want to thank the president of the heart failure group, Wahid, my good friend Waril Al-Habib, for the kind invitation to talk about heart failure. These are my disclosure. I participate in several of acute heart failure trials that are ongoing or just finished. And let me start by giving you some data that we'll discuss in more details in a few seconds. Heart failure is the emerging epidemic of the 21st century. First of all, in the European Society of Cardiology countries, there are more than 15 million patients with heart failure. The prevalence and the incidence increased. The heart failure is costly. In most countries, they spend more than 2% of national expenditure on health in heart failure. And heart failure has poor outcome, influences both the quantity but also the quality of life of these patients with heart failure. And let me present you some data that I think that are very important. These are data from 2 acute heart failure trials. Those acute heart failure, a diuretic trial, and hs-HF, which is, as you know, the trial on ultrafiltration. As you can see, the death or hospitalization or emergency room visit, it is at 60 days 40% in this trial, and in hs-HF, death or heart failure hospitalization is 40% at 2 months. So what does it mean? That from all these patients that you see in your CCU or in your ward, you should remember that 40% of these patients will be rehospitalized or die within the next couple of months. And of course, the situation is similar also in heart failure, in chronic heart failure. You can see on the left part the Italian registry, and as you can see, the numbers are better than acute heart failure, but still morbidity and mortality is very high. And let me remind you something else. Of course, acute and chronic heart failure is one syndrome, one disease, but probably there are some differences that we should always have in mind and we should take into consideration. This is a chronic heart failure trial. This is the DIDS, the trial where digoxin has been evaluated in patients, 7,000 patients with heart failure and sinus rhythm. And these are the patients with and without a hospitalization for heart failure. Remember that these are patients with chronic heart failure. However, when one hospitalization occurred, the mortality in these patients hospitalized continues to increase during the 5-6 years of follow-up. So something is different, maybe something like acute coronary syndrome, acute myocardial infarction, and stable ischemic heart disease, but still we don't understand the pathophysiology. Moreover, heart failure has a very bad effect on quality of life. Depression, anxiety, quality of life is reduced more than any other chronic disease, and in these patients with heart failure, with advanced heart failure, higher depression score and compared with patients with advanced cancer. And of course, you know, we have already discussed the economic burden of chronic heart failure, and 69% of this hospitalization accounts for most heart failure associated costs. The main problem, the main symptom of these patients with hospitalized for acute heart failure is shortness of breath, dyspnea. All patients, practically all patients hospitalized for acute heart failure have shortness of breath. And we know that congestion plays an important role in all patients. As you know, we know now that these patients on the left without peripheral edema, without ascites, probably are slightly different or very different from those patients who deteriorate over days or weeks with ascites, with peripheral edema. However, congestion is important pathophysiological process in both patients. And one of the problems that we face, and these are data from the from the Heart Failure Association registry, the registry of the European Society of Cardiology in Acute and Chronic Heart Failure. As you can see, and please pay attention here in the middle, at discharge, at least 24% of patients, they have congestion. So 1 out of 4 patients discharged from the hospital, they still have signs and or symptoms of congestion. And is this important? As you can see also here, it is very important because mortality in this patient is double compared to those without congestion. And this is, the situation is similar in US, whereas you can see only 60% of patients, they have a significant improvement. There is no change or mild improvement in 30% of patients, and all those patients with signs and symptoms of congestion after hospitalization, they have increased mortality. Several years ago, with Mihai Georgiadi, we hypothesized that with each decompensation, there is myocardial and or renal damage leading to further progression of the disease. And it's very well known now that heart failure leads to adverse effects on the heart, lungs, kidney, and vasculature, and is not only inflammation, is not only cell death by necrosis apoptosis, even the comorbidities play an important role, and of course neurohormonal activation. And we have here in the audience the father of the current therapy in chronic heart failure, the ACE inhibitors and beta blocker, Professor Carl Swedberg. And, but what is known that all these factors, they lead to adverse effects on the heart, lungs, kidneys, and vasculature. And more than 20 years ago, we hypothesized that this activation of compensatory mechanisms leads to cell death by apoptosis and necrosis. This leads further to fibrosis, and fibrosis by itself leads to a vicious cycle of more apoptosis and necrosis, more myocardial and renal injury, more activation of compensatory mechanism and progression of the disease. And all this troponin elevation has been proven, and several mechanisms have been proposed for this cell death in our patients with chronic heart failure. Of course, now we have another problem to understand better the pathophysiology of heart failure, because of the high sensitivity troponins, and we'll discuss this in a while. But what is clear, also with these high sensitivity troponins, if we have an increase more than 20%, these patients with an increase, they have higher mortality compared to those patients with an increase less than 20% from baseline. And in RELAX-1, we found that the patients who were on serelaxins, they have a lower percentage of patients had an increase in high sensitivity troponin T. And this, of course, leads to a new understanding, because many of these patients who in the past were unstable angina, when they have, of course, the adequate clinical picture, they are now categorized in patients without STEMI. And another area where we have several changes during the acute phase is the interstitial tissue. We know that in heart failure, and especially in patients with acute heart failure, we have an increased expression of metalloproteinases, and also an increase in the activity of metalloproteinases, and this leads to alteration in extracellular matrix structure. These changes in collagen synthesis and degradation, and changes in collagen structure, they lead also to increase collagen synthesis, and also at the end to higher percentage of fibrosis in the heart. And it's very well known now that these episodes of acute heart failure syndrome are associated with marked and transient increases in markers for extracellular matrix turnover, as you can see here in collagen, MMP2, but also the inhibitor TIMP1 increases during these episodes of acute heart failure. Another very important area of where we have many developments recently, and Professor Ponikovsky will discuss this in more detail, are the comorbidities. All these patients with heart failure, they have in different registries, as you can see here in the Adhere and Optimize, the US registry, the European Society of Cardiology and Heart Failure Association registry, but also the registry from Latin America, that all these patients with acute heart failure, they have many comorbidities. They have atrial fibrillation, 1/3 of them, 50% of them, they have diabetes, 1/3 of them, they have renal insufficiency, and at least 1/3 of them, they have a history of chronic respiratory disease. And most of these comorbidities increase mortality in these patients with heart failure. These are data from one of the recent trials on acute heart failure, the Everest trial, where, as you can see in the upper part, patients with diabetes, they have this is the column with the epidemiological data in patients with diabetes, and this is in patients without diabetes. And as you can see, the all-cause mortality, the cardiovascular mortality, and cardiovascular death and hospitalization is much higher in these patients with diabetes compared to those patients without diabetes. And the same is true also for the patients with chronic kidney disease. Patients with chronic kidney disease, they have higher all-cause mortality, higher cardiovascular mortality, and higher percentage of cardiovascular death and heart failure hospitalization compared to those without chronic kidney disease. And of course, this is true despite the fact that we don't have good definition for many of these comorbidities. And let me just discuss, let's say, about the most common, the worsening renal function. We don't have a good definition still to define how can we define the worsening heart failure function in these patients with acute heart failure. This is a table from European Heart Journal where we went, we searched the literature and we tried to identify the different definitions that have been used in registry, in trials, and as you can see, there are more than 10 different definitions for worsening heart failure. The 0.3 is the definition that has been used also by FDA in the past. Of course, the situation is more complex than we thought in the past. But what is clear that even if creatinine does not change, even if you have just an increase in cystatin C, these patients with an increase in cystatin C in RELAX-1, what we found, they had a much higher mortality, and also we found also lower percentage of patients in this trial in the group on serelaxin had an increase in cystatin C. I will not discuss treatment. Professor Ponikovsky will discuss the treatment. So I spent my last few minutes just in a couple of slides on acute heart failure treatment and 3 or 4 slides on chronic heart failure management in general. We have 3 different phases in the emergency room or in the CCU or in the general ICU according to the structure of the health system and the hospital. We have the intermediate and hospital phase, and now it's clear that we need a long-term pre-discharge management plan. And the problem is that until now, although we have still diuretics, vasodilators, opiates, and inotropes, we don't have good evidence. As you can see, we have only level of evidence B or C based on expert consensus and what we all want, and this is from the European Society of Cardiology. Actually, this is from the slide set of Carl Swedberg guidelines published some year ago, but I'm sure that Professor Ponikovsky, who is the chair of the next guidelines committee, will keep this. that we don't have any class 1 recommendation level of evidence A for acute heart failure. What about chronic? Chronic, more or less, we want the same, to reduce morbidity and mortality. But here, thanks to Carl mainly, we have very good evidence. In all these patients, we have triple therapy, ACE inhibitors, beta blockers, mineralocorticoid receptor antagonist MRA. They are still symptomatic and diuretic. And because of this, in prognosis improved for the last 20 years. And I think that it's important that most patients with chronic heart failure are treated in accordance with the ESC guidelines. As you can see, more than 90% of patients, they are on ACE inhibitors or ARB. More than 92% of patients, they are on beta blockers. 67% of these patients are on MRAs, and these are data from the European Society of Cardiology Heart Failure Association registry, despite the fact, of course, that only a small percentage of these patients are at target dosage of the recommended pharmacological treatment. Despite this fact, despite the fact that these therapies improve prognosis in patients with chronic heart failure, as you can see in this slide, you can see that prognosis improved compared to early 80s. However, if you go and evaluate this survival curve, you can see that 5-year mortality in these patients with chronic heart failure is still above 50%. So we need something new here, because the mortality of heart failure remains malignant, greater or similar to that of several cancers. And also, we need also drugs that reduce also hospitalization, because at least 30% of patients during 1 year follow-up in the HFA registry, they had a hospitalization. 75% of this hospitalization were the reason, the etiology, the cause was cardiovascular, and 25% the cause of hospitalization was non-cardiovascular. So we need also to reduce hospitalization even in these patients with chronic heart failure. Is there anything new there? Professor Ponikovsky will discuss the management in acute. In chronic, there was recently a meta-analysis published that maybe the results of beta blockers, the efficacy of beta blockers for preventing death in patients with atrial fibrillation is not as good as in those with sinus rhythm. We need to discuss this probably more. And recently, in last September in Barcelona, John McMurray and Milton Packer presented the results of Paradigm heart failure trial, where the LCZ696, an ARB, an inhibitor of neprilysin, decreased mortality, cardiovascular death or heart failure hospitalization by 20% in these patients with chronic heart failure. And of course, last but not least, 40% of our patients, they have heart failure with preserved ejection fraction. In all trials, we didn't see a reduction in mortality. In Carl's trial, in Charm Preserve, there was a reduction in hospitalization. This is the best that we've seen so far in this population with heart failure and preserved ejection fraction. In conclusion, dear colleagues, there is an unmet need to identify safe and effective therapies for patients with acute heart failure, given the high post-discharge morbidity and mortality experienced by this group. And the majority of these acute heart failure patients with hospitalized with heart failure are patients that we already know, patients with worsening chronic heart failure. Thank you very much for your attention.